Hi, John. Are you over there? Hello? Can you hear me, Mr. John?
Hey Ahmed, how you doing? You there?
Hi,
Come
Mr.
on.
John. Can you hear me? Hello? Can you hear me, Mr. John?
Yeah, hi, how you doing?
I'm good. How about yourself?
Very good. It sounds like you're in an echo chamber. Let's see, you got your picture there, Ahmed?
Yeah,
Do you have a picture?
yeah.
There you go.
Yeah. Sir, have you contacted with Dr. Asil or not yet?
With Dr. Sabea?
Yeah.
No, I haven't heard from her. Have you?
Okay, I'm gonna talk with her right now.
Okay. Yep, 20 minutes.
Okay. Hi everyone. The lecture will be started a few minutes later. I mean, I think it's 10 minutes to start the webinar. So wait 10 minutes and then we will start the lecture.
Yeah, about 10 minutes, about 10 minutes. Yeah, you can talk to Abraham. Feel free. It's a free forum.
I just talked with Dr. Asil. She said that a few minutes, maybe 2 3 minutes, to join us. So everything is going good.
Oh, okay. So you talked to Dr. Sabea?
Yeah, I did.
Oh, good. She didn't forget about it, did she? I hope she didn't. When's the last time you talked to her, Abraham? When's the last time you talked to Dr. Sabea?
I mean, Dr. Asil, I just talked with her maybe 5 minutes ago.
Oh, okay, okay. But before that, did she know she was in the webcast?
What?
Did she know she had a webcast?
Of course, she just review her, her
Oh,
presentation.
oh, I
Yeah.
thought she forgot. I thought she forgot.
No, no,
I
she is
thought
very,
you, I thought you would let her forget, is what I
no, no,
want to say.
no, no, we are very excited to have this webinar. So we just, counted, every minute to,
Good. This is a big day for you, right? The city is closed. The city is closed and everyone's watching on the screens,
good.
right? Right? No, not quite.
Where are they? Good.
Well, listen, Abraham, I'm trying to change the model of a webcast so that vendors pay for the webcast. Like they sponsor it. Do you know what I mean?
Did you talk with me, sir?
Yeah, I'm trying to get sponsors for the webcasts.
Okay, just a minute, just a minute. Okay,
Can you
let's
hear
see.
me?
Yeah, but I'd like just to add Dr. Asil.
Oh, okay. Yep.
Hello, everyone.
Hello.
Can you hear me well?
Yes, it's Dr. Sabea. How are you?
I'm great. How are you?
Very
Long time no
good.
see or talk.
That's right. I've seen you a long time ago,
Yes, yes, I've been
right?
super busy. Hi, Dr. Ahmed.
Hi, Dr. Asil. How are you? Ramadan
Um,
Kareem. Yes.
رمضان كريم علينا وعليكم يا رب. Yes, I've been busy and yeah, I think I can't focus on so many things at the same time. I need to work on that.
Oh, well, you're going to be working at that the rest of your life.
Yes, I know. I
It's
have
not the
to.
career to get into if you just can't multitask.
I know, I know. Yes,
You
I need
got,
to work
you
on this.
guys, you got to multitask to the max.
Yes,
Probably more than most docs. Probably more.
definitely, definitely. That's for sure.
Yeah. Okay, so I'm going to introduce Ahmed, and then Ahmed's going to introduce you. We have
Great.
6 minutes to go. We have plenty of time.
Yeah.
So you came back from London to Jordan.
I went for a visit in London. I was not working in London.
Oh, okay.
I went for a fellowship in Austria last year,
Oh, okay.
and I've been working with Dr. Spey since then.
Oh, okay. The
Yeah.
fellowship was in minimally invasive spine, correct?
No, the fellowship was in endoscopy and skull base.
There's a
It
slight
was a
difference.
short one. It's a short one, but yeah, hopefully I'm working on other fellowships for the future. Fingers crossed.
Where do you want to go?
Yeah, I mean, the world is my oyster.
That's
I'm
right.
applying everywhere. Yeah,
Use this as a tool. Use the Zoom as a tool.
sure, to connect and
And yes, to connect to wherever you want to go. Wherever
definitely.
you want to go, in the skull-based area.
Yep, yep.
Matter of fact, I'm trying to get a trauma. Well, anyways, we'll keep in touch with anything
Shh.
that I do run. But yeah, my suggestion is to get into a Zoom, invite them to a Zoom that you're going to give, or
Yes, that's true.
see if they want to present something on minimally invasive, and you could participate. You could arrange it. You know what I'm
Yes, that's
saying?
true. Yes, that's true.
That would be good because it would save them effort of arranging it, and you could bring some people that you know,
Yeah.
and away we go. And then you make some people you know. I mean, let's face it, when you don't know that when you start how important it is about people who you know, but of course after a while you get the message that it really
Connections,
helps. Yeah.
Connections is everything. Yeah.
Yes, yes, and this is a great tool for connection. Great
Yes,
tool.
I agree. I
I'm
agree.
not a neurosurgeon, and look what I'm doing. You know,
Yeah.
it's just connections, meeting people and then meeting other people and trying to find something you have common ground on
That's true.
Collaborate.
Yeah. I just wanted to ask, how much time do we have? Or is it like an
No, it's free form,
okay,
45 minutes,
okay,
whatever,
okay.
and
I'll try to
15
keep it.
minutes. Yeah, no, you don't have to
Yeah.
be tight. It's not strict. However
Okay.
you feel comfortable.
It will be around that because basically you can't say everything about the brain anatomy in one session. I mean,
Yeah, of course,
we'll
of
just
course,
be highlighting some things and yeah.
of course.
Yep. So thank you, Dr. Ahmed, for this invitation. You're always so active. You're more active than me.
No, it's been a pleasure, doctor, and of course, it is a great opportunity for me to have enough knowledge to start neurosurgery residency soon, inshallah.
Hopefully. Good luck, Dr. Ahmed.
Well, Ahmed is going to be successful from what I've seen when working with him. He's very ambitious. He's on the go. He knows social media. He knows more than most of the people I know.
I agree.
He knows what's up, which Ahmed, you like what's up, which is great. I think it's a great tool. What's up?
Yeah.
Thank you, Mr. John. That means a lot for me.
Well, you know, it's good. You put the effort in, and it helps. And just like I was saying, this Dr. Shabea, you know, for me to network with you, of course I'd recommend you. Of course I would try to help
Definitely.
you. I would help you
Definitely.
because I've seen how hard you work and how dedicated you are to putting
Yes,
a
I
good
agree.
program on. So you just keep on what you're doing. You're going to be
Yes.
successful.
Yes.
You know,
People
Mr.
from
John,
Yemen.
sorry.
Our people from Yemen.
They're lucky. They're
The
lucky to
great
have
people of
him.
Yemen. The great people of Yemen.
Thank you. You know, doctor, the first neurosurgeon I have recognized and have a relationship with him is Prof. Sabir. You know, even before all the neurosurgeons, those are in Yemen or in another country. So Prof. Sabir is the first neurosurgeon that I have met and talked with.
Yes, I know that. Yes, and he really admires you, and he really admires how much you work and how much effort you put in this. So we are all waiting to see how successful you will be, Dr. Ahmed.
Inshallah, you know, he always, support me and, just contact with him means a lot for me.
We'll all be of the most help to you, inshallah.
Okay, very good. You ready to start?
Yep.
Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is good afternoon, Dr. Bennett, telecasting from beautiful Miami Beach, sunny Miami Beach. Today we have the pleasure of having the Yemen Neurosurgery Grand Rounds associated with the Walter Gandy Association. And I'd like to introduce Ahmed, who put everything together. He's a hard worker. Thank you. It's all yours, Ahmed.
Yeah, thank you, Mr. John. It's my pleasure and honor to have this webinar with you and also with Dr. Asil. I am Ahmed Al-Ghanimi, the president of Walter and the Surgical Club of Yemen, and I'm also an executive administrator at Walter E. Dandy Neurosurgical Society globally. It means it is my pleasure and honor to invite and introduce Dr. Asil Sabir, who is a board certified neurosurgeon and also has a fellowship in skull base and endoscopy from Australia. Hi, Dr. Asil.
Hello, Ahmed. Hello, Dr. John, and thank you for the kind invitation. I will start by sharing my screen right away. Can you see my screen?
Yeah, perfect.
Great. Hello, everyone. Hello again. My name is Dr. Asil Sbeih. I'm a board-certified neurosurgeon from Jordan. Ramadan Mubarak to everyone who is fasting and celebrating. When I was first approached by Dr. Ahmed to give this lecture, I got reminded of how difficult it was for me as a student, as a medical student, to navigate through brain MRI and the brain CT scans, and it's a very important concept to know, and we should be able to read our own scans as neurosurgeons. And it's basic, but it's very important. And even as you advance in your career and in your practice, you can still face some scans that are a bit tricky. So you have to keep remembering your scans and how the normal anatomy looks like. So I wanted to make a small introduction about the MRI itself before we dig into the normal brain MRI. So radiology today uses three kinds of technology to give an image. So we can either transmit energy like the X-rays, like the X-ray, like the CT scan, like the DEXA scan, or we can use the reflection of energy like we use with the ultrasound, or we use the emission of energy, which is the basis of the MRI machine. And we'll talk about it now. The MRI is the most sensitive imaging modality for brain and the spine, and the basis of which an image gets produced in the MRI is simple to say, but quite complicated. So basically, we're 70% water content. We have a lot of hydrogen atoms. The MRI is a big magnet. And when the patient goes into this big magnet, the protons in the hydrogen atoms in our body gives out an electromagnetic signal back to the MRI machine. And according to the intensity of the signal, the MRI creates the image. And that's why we describe findings in the MRI as intense. So it's either hyper intense or hypo intense. And our reference point is always the gray matter. So for example, in all of the sequences of the MRI, the bone is the dimmest structure because it has the lowest density of the protons. So the bone is almost always hypointense. The MRI, and especially modern MRI, has so many sequences. And again, I am keeping in mind that we have a junior audience amongst us. So we'll keep it basic and simple. We'll be talking about the T1 and the T2 sequences, but please bear in mind that there are so many other sequences out there. So usually in our daily practice, in the clinic, in the ER, we use the T1 to just look at the brain with a quick look to see if there's anything grossly abnormal. And with the T2, it delineates the pathological changes more accurately, let's say. So we use it to look for the pathological changes. The most important difference between T1 and T2 is that in the T2, the CSF is white. In T1, the CSF is black. Gray matter in both is gray. White matter is white in T1. It's darker gray in T2. Bone is always black and fat is always white. So we should keep this in mind as we look at the scans. Another important concept is to keep the orientation of the scans in mind. Again, I am talking to the junior audience, to the more junior audience. We have a mirror image, so left is right, right is left, because we should imagine that we're looking at the patient from the feet up. So the feet of the patient is the closest to us, and the head is far, and we're looking from the feet up. So left is right, right is left. And believe you me, there are a lot of times where people get confused and we can end up with wrong side surgery because we have messed up the orientation. So this is basic yet of most importance. And the history of the MRI dates back to a long time ago. The basics, the physics of it started in 1930s at Columbia University, and after which more work was done, built on that work. until in the 1940s, the foundations of the NMR, which is nuclear magnetic resonance, was founded. These are the pioneers, a few of the pioneers who were involved in the development of the MRI machine. So this is Mr. Gorter in 1936. He had the first attempt to produce an image and to observe the nuclear spin. Mr. Rabi built on his work, and eventually Mr. Zaviosky in 1944 was able to discover the electron spin resonance, which is the basic physics technology to do an MRI image. And then these two gentlemen, they were Mr. Bloch and Mr. Purcell. They were awarded the 1952 Nobel Prize in Physics for their development of new ways to measure the NMR, and basically which paved the way for the newer generation and for the MRI machine that we know now. And these gentlemen also, they have basically Mr. Ernst. He laid the foundation and the science for the modern day physics, for the modern day MRI. Mr. Lauterbur and Mansfield, they both won the Nobel Prize in Physiology and Medicine in 2003 for their discoveries and their contribution to medicine with the MRI machine. Basically, the first MRI body scan of a human being was performed in 1977. Before that, there were some attempts to image anesthetized rats and etc. But the first one was done in 1977. The first clinical MRI system was established and installed in the early 1980s in Korea, and was followed or at the same time it was done in London. And I know a story about this. I'm not sure how accurate it is, but at the time, pilots flying over London, over certain areas of London, have reported feeling this strange pull. And at the time, no one knew that there was work done to do this MRI. And later on, they found out that this particular area was the area where they were developing the MRI machine, which is fascinating. And this brings me to another cool factoid. The 1.5 Tesla MRI, which is the most basic one, has the gravitational pull that is equivalent to 21,000 times the gravitational pull of Earth. So you can imagine this super powerful magnet that is able to give us these very nice images about for the brain and the rest of our body. So it's super, super cool. This is a timeline of since the MRI started until the latest technology. So we can see that it started very early on, 1924. And now we have 11.7 Tesla MRI. I believe they're working on the 14 Tesla MRI. And these, I can tell you, they're basically used for research purposes, not for clinical use. But as we all know, with time, they can be commercialized and used in our daily life. And these images are from the very early MRI machines. This is the very early one, and this is one of the earliest images that were produced then of the pleural cavity and the pericardium. And I think we can appreciate how far the technology has come since then. Another point that should be made when reading the MRI is that we all have to have our own system reading the image. So it should be a systematic approach. You will hear different people, different doctors telling you different ways of how to read a brain MRI. You should make your own way, in a way that you don't miss anything, because as we know, we're not only imaging the brain. Parts of the face and the neck show up in these scans, and they may have pathologies that are related to whatever pathology that is in the brain. So we should be able to pick up on all of these changes. So you either start looking at the images from the midline going more laterally, you can start anterior going posterior, you can start by looking at the bone, and then looking at the gray and white matter going inside towards the ventricles, and then the vessels. You choose. Each one of us should choose their way, but you should have a way of how to read a brain MRI. Okay, so I have these images, and I have a small surprise for everyone later on, so please stay tuned. So we'll start with the normal brain MRI. T2, I know the title of the webinar is T1, but I believe T2 weighted images give a more clarified view of the normal anatomy. So we'll start with this. We'll start with the axial T2 images. Very basic image, very basic, I know, but we should start with this for the more junior doctors among us. So this is an axial cut. It's a way up. And when we're looking at this image at this level, we should all be looking for this, the central sulcus, the omega sign, the inverted omega sign. A lot of decisions will and can be made according to what we localize in accordance to the central sulcus. So we should be able to see it always. We should look for it to know which the precentral and postcentral gyrus are, where is our pathology in regards to the motor and sensory cortex, etc. So omega sign here and omega sign here, it's more prominent on the right side. Here we have the falx and we have the superior sagittal sinus. We'll go down. We're going down with the cuts. I know I said we should be systematic, but for the purpose of this lecture, because I need to point out random things for you, I cannot basically teach and tell you every single piece of anatomy in the images. The idea of this lecture is to point out how normal structures look like and what to look for when we see an image, when we look at an image. So here we can see the beginning of the body of the lateral ventricles. And as we know, the body of the corpus callosum, it hangs over. So this is the body of the corpus callosum starting to show here with the body of the lateral ventricles. And I'll be talking about the gyri and the sulci with other images. Again, body of the lateral ventricle here, septum lucidum, superior sagittal sinus. We'll go further down. Anterior horn of the lateral ventricle, occipital horn, we have septum lucidum here. These projections are the choroid plexus. Here we have the genu of the corpus callosum. We should be able to identify the parts of the structures that we're talking about. So the corpus callosum has a rostrum, genu, body and tail, and the splenium. We should be able to know which part am I looking at, because we should be able to describe our pathology. Where is it? So this is the genu of the corpus callosum. This is the splenium of the corpus callosum. This is the head of the caudate. The head of the caudate bulges into the frontal horn of the lateral ventricle. Here we have the putamen and the thalamus, all parts of the basal ganglia. And as we know, the anterior limb of the internal capsule is here, the genu and the posterior limb. And we have here parts of the frontal sinus starting to show up. Again, I'll start from up and going down. This is parts of the frontal sinus again showing here. Genu of the corpus callosum, frontal horn. We have the septum lucidum here, occipital horns and the choroid plexus. Here we can see super major important anatomical landmarks, the internal cerebral veins running in the roof of the third ventricle. And here we have again the head of caudate, the putamen and the thalamus, the internal capsule with its anterior genu and posterior limbs here. Also, yeah, I think the splenium and the genu of the corpus callosum here. Going more down, again, frontal sinus. This is part of the anterior cerebral veins. This is what we can still see of the frontal horn of the lateral ventricle, head of caudate, and the putamen, and the globus pallidus and the thalamus, the basal ganglia with the internal capsule running into them. Here we have the columns of the fornix. Also, we should be able to, again, know which part am I looking at. So these are the columns of the fornix. Here we have the foramen of Monro, and we should appreciate basically they're touching the foramen of Monro and the genu of the corpus callosum here. We should keep this in mind. The slit of the third ventricle starting to show. Internal cerebral veins, again, super important anatomical landmarks. They're going into the vein of Galen, which also has tributaries from the basal vein of Rosenthal. I mean, there's so much to say, a lot to see, but you should be able to pick up on this very quickly as you see the images. You should be able to know all of these anatomical landmarks as you go. Again, frontal sinus here. Here we can see the sylvian fissure, anterior cerebral veins here, head of caudate, putamen, globus pallidus, third ventricle. Here, this very nice white matter tract is the anterior commissure. This is the third ventricle here, and the pineal gland is the posteriorly to the third ventricle. It's posterior to the third ventricle. And here we have the superior vermian vein also going into the vein of Galen. And these are the occipital horns. And if you can appreciate, I don't know if it's very obvious on these images, if you can see here the darker line here and here. If you remember, we said that white matter looks darker gray on T2. These are the optic tracts here and here going to the occipital lobes. We're going more down, also frontal sinus, and here we start seeing the parts of the roof of the orbit here. So this is the superior rectus muscle. Wow! As I told you, the image will give us parts of the brain and parts of the face and parts of the rest of the face. So we should be able to know what am I looking at. So this is the superior rectus muscle here showing anterior cerebral veins, sylvian fissure with the middle cerebral arteries running in it. Third ventricle, here we have these small dots of the hypothalamus, superior vermian vein, and this is the tentorium cerebelli. This is how it looks like on T2. Going further down. Just give me a moment, please. So this is again the frontal sinus. Again, we are looking at the extraocular muscles. They are showing here. We can see the olfactory bulbs. We can see the crista galli. We can see the gyrus rectus here and here. Anterior cerebral arteries. Still parts of the sylvian fissure here and here. The sphenoidal parts. Here we can see the mammillary bodies. We can see the optic tracts here and here. The hypothalamus. Here we can see the midbrain. And again, we should know which level we are looking at. So we're going down. This is part of the midbrain. I should be able to know which structures I see at this cut. So I should be able to anticipate, I should be able to imagine that at this cut, I should be seeing this cranial nerve, I should be seeing this artery, I should be seeing this vein, these complexes, in order to know what's there. So here we're at the level of the midbrain. We have the crus cerebri here and here. We have the interpeduncular cistern here, ambient cistern, and the quadrigeminal cistern. It's not really obvious in these cuts, but here we have the red nucleus and the substantia nigra here and here. The culmen, part of the anterior lobe of the cerebellum, starting to show here. There's so much to look at. Going further down, now we're starting to see the ethmoidal air cells. And now we can see other parts of the eye. Another, again, olfactory nerves here. Maybe we can appreciate the start of the optic nerves here, the temporal pole. These are the vascular voids of the internal carotid artery, which gives branch to the anterior cerebral and the middle cerebral. And in later cuts, we can see the posterior communicating going backwards. I should always look at a structure and ask myself, what is this? What am I looking at? This is basically the posterior cerebral artery coming from the basilar artery, from the tip of the basilar artery, from the most terminal branch of the basilar artery. Again, the quadrigeminal cistern. We can see the start of the aqueduct of Sylvius. Here we can see the hippocampus. So I should be able to see the hippocampus, and here's the uncus. This is what we call an uncal herniation because it starts here. It affects the oculomotor nerve. In other images, in more detailed images, I might be able to see it. So again, I should anticipate what will I see at this cut. Optic nerve, medial rectus, lateral rectus. These are the ethmoidal air cells here. Again, basilar. Here is the internal carotid artery. This is the basilar. This is the PCOM. As I told you, we went backwards to meet with the posterior cerebral. And here we can see the infundibulum of the pituitary. And we should not forget that we have extracranial structures that we should be able to know. So this is the temporalis, for example. Again, ethmoidal air cells, nasal septum are going down. Medial rectus, lateral rectus, the eyeball, basilar, pituitary, internal carotids. I mean, this is magnificent. This is the pons. This is how it looks like here. This is the start of the fourth ventricle. This is the trochlear nerve. It's very thin. It's a very small nerve, but here we can see it in this cut. Again, ethmoidal air cells, nasal septum, sphenoid. Now we can see. I can imagine that I'm going more down. These are the internal carotids. This is the pons. This is the trigeminal nerve going into Meckel's cave. Temporal lobes, temporalis muscle. I mean, we should be always oriented to what we're looking at. Again, nasal septum, sphenoid sinus, temporalis. As I said, we should not forget about the extracranial parts. Basilar. Now we have the pons. This is the middle cerebellar peduncle going to the cerebellum. This is the biggest peduncle. So this is how it looks like when it's going into the cerebellum. Now we have the internal acoustic meatus. This is the cerebellopontine area or angle, and this is the cerebellopontine cistern. We have the internal acoustic meatus here and here with the 7th and 8th nerve going inside. Now we can see it in this cut. So facial on the anterior vestibulocochlear posteriorly going in to the internal auditory meatus going to the cochlea. We can see the cochlea here. Here we can see a vessel, which is probably the ICA, because it's a complex with the 7th and 8th nerves. So I should be able to know that at the level of the pons, when I see the 7th and 8th going in, I will be seeing the ICA. Or when I'm at the pons, I will be seeing the 7th and 8th nerves going into the ICA. This is how I orient myself. I always keep a reference point that I know for a fact, I know for sure in any cut that I see, and I make my predictions or assumptions according to that. So again, sphenoid, maxillary sinuses here, nasal septum. We will be seeing the whole face, the whole head, and we should be able to identify each and every structure. And this is the vessel void of the internal carotid going into the petrous bone. And this is how it looks like. Again, nasal septum, maxillary sinuses. These are the nasolacrimal ducts draining into the inferior turbinate. Internal carotid of the petrous part, basilar artery. This is, again, we're at the level of the medulla, so we're further down. So this is temporomandibular joint. This is the glossopharyngeal. This is the fourth. This is part of the inferior cerebellar vermis. This is cisterna magna. All of this anatomy, I should be able to know it right ahead. So, yeah, I think I will continue to the, yeah, I think this is the last one from the axial images. I will just say this, talk about this one. Nasal septum turbinates. This is how the turbinates look like when they're inflamed and edematous and enlarged. Okay, so we should be able to see this and recognize it. Maxillary sinuses. This is the nasopharynx. We're way down. This is the spinal cord. Two vertebrals still running at the sides until they meet at the pontomedullary junction and form the basilar artery. These are the mastoidal air cells. They're black because they have air. And yes, I think this concludes the axial cuts. Now we'll go to the sagittal T2 images. Again, as I told you, we'll be talking about the gyri with later images, but with the sagittal ones, it's easy and more. I think we can imagine more with the sagittal images. So this is the middle frontal gyrus. We can't see the superior because it's more medial. So this is the middle frontal gyrus. This is pars triangularis. This is pars opercularis, which has the Broca's area at the dominant hemisphere. We have the Sylvian fissure here. We have the supramarginal and the angular gyri here, the superior and the middle temporal gyri here. Again, we should be able to be oriented where we are looking. So this is the caudate. This is how it looks like from the sagittal cut. The caudate is a C-shaped structure that is sitting on top of the putamen on the medial side. So it's hugging the putamen. The head and the body and the tail goes like this. It's like a C-shaped. So this is the caudate. This is the putamen. I should be able to know this. I know this image is not very, very clear, but these are the corona radiata fibers forming the posterior limb of the internal capsule. This is how it looks like. This is part of the middle cerebral artery. This is the temporal bone, temporal lobe. This is the vertebral artery. I mean, someone can be pointing at this and asking me, what is this? And it would take me a minute to know that this is the vertebral artery. So you should be able to know this. This is here the frontal sinus. This is the maxillary sinus. We're going more medial. We're going towards the midline. So this is the thalamus. This is the remaining of the caudate nucleus that we can still see. This is the lateral ventricle. This is part of the corpus callosum here. Internal carotid. This is the paraclival part, and this is going into the cavernous sinus. Again, vertebral body. These are the ethmoidal air cells that we just talked about. So I should be able to recognize this. Again, I mean, there's so much to say about this, but we'll go, I'll go from the anterior to posterior. So this is frontal sinus. These are the sphenoid sinus. This is the clivus. This is how the clivus looks like. And you will be amazed and surprised that the clivus looks in many different ways, normally in many different scans. So you should be able to know that this is how the clivus looks like. This is the optic chiasm. This is the pituitary. This is the genu of the corpus callosum and the body and the splenium here. The lateral ventricle, the thalamus. I should be able to know this. Pons with the middle cerebellar peduncle going into the cerebellum, as we just talked about. This is the vertebral artery that is the intradural part going inside and that will form the basilar artery at the pontomedullary junction. This image is right at the midline, so it's perfectly midline. Ethmoidal air cells, sphenoid sinus, clivus here, nasopharynx here. So we're done with the sinuses and the air spaces. We have the optic chiasm here because we're right at the middle. We have the pituitary gland here. We have the mammillary bodies here. We have super important landmarks here and here, especially for the functional people, the anterior commissure and the posterior commissure here and here. We have the thalamus or the massa intermedia, since we're perfectly at the midline. The corpus callosum with the cingulum right above it. Here we have the internal cerebral veins, as I told you, very important landmarks running in the roof of the third ventricle, going backwards to drain into the vein of Galen, which also takes from the basal vein of Rosenthal, and then they drain into the straight sinus and they all go with to the trochlear hierophily. Fourth ventricle, superior medullary velum, inferior medullary velum. This is the tonsil, pons, medulla. This is basilar. As I told you, it forms at the pontomedullary junction. Pineal gland. There's so much. I included some coronal images just for orientation, so that we can have an idea and maybe learn a little bit more than other people. So again, we should know what we're looking at. So these are the ethmoidal air cells, maxillary sinuses, the conchae, the middle and the superior and the middle ones. This is the optic nerve. This is how it looks like. And we have the extraocular muscles here. So medial rectus, lateral rectus, inferior oblique. We have the superior rectus with the superior levator palpebrae over it. We have the crista galli with the olfactory bulbs here, and they run backwards as the olfactory nerves. Temporalis. Again, this is the optic nerve running into the optic canal. This is the temporal lobe, the temporal pole. I'll go more back. Optic nerve. These are the anterior cerebral arteries going up. This is more back. So sphenoid, internal carotid, and internal carotid here. This is the optic nerve here and the optic nerve here, and they will be joining to form the optic chiasm a little bit further backwards. This is the middle cerebral. These are the anterior cerebrals. These are the columns of the fornix. Lateral ventricle. This is the head of caudate. This is the putamen, and as we said, the internal capsule is running through them. So this is how the normal anatomy looks like. So optic chiasm, internal carotid going medially to give us the anterior cerebral artery, and then laterally as the middle cerebral arteries. More backwards, we have the basilar giving the posterior cerebral here and here, that will be joined with the PCOM. We have the optic tracts here, the slit of the third ventricle showing with the columns of the fornix above, and as we said, the roof of the third ventricle has the internal cerebral arteries. We have here the body of the corpus callosum with the lateral ventricles here and here, head of caudate, anterior limb of the corpus callosum, putamen, and the globus pallidus here. I mean, this is amazing. Going more backwards, I will be showing you just here the foramen of Monro and here the mammillary bodies. We should be able to identify these. These very small dots are the trigeminal nerves because they're going at us, towards us, so we'll be seeing them as two round dots. So these are the trigeminal nerves here, the third internal cerebral veins. As we said, they are at the roof of the third ventricle. So this is the third ventricle, and this is the roof of the third ventricle where the internal cerebral veins run through. What else? Cochlea, vertebral arteries, where they will meet and they form the basilar. Internal auditory canal here and here, as we said, with the 7th and 8th and ICA complex at this level. These are the dentate nuclei here and here. We have the thalamus here. We have the anterior. We have the splenium of the corpus callosum here. Pineal gland. Splenium. This is the atrium of the lateral ventricle. We're going back. Again, we can still see the internal cerebral veins here. Going further back, atrium, vein of Galen, where the internal cerebral veins, they drain into and they go to the straight sinus. This is the most posterior cut, trochlear hierophily, and we have the transverse sinus here and here. And yes, I think we covered basically some good ground. And the surprise is that when I was doing my due diligence for this lecture, I found a super cool book that is 7 Tesla, that has 7 Tesla MRI images. And it's so long, it has so many images, it was impossible to include so many in the lecture, so I chose some, and I'll be talking about the gyri and the at the images, and I will be showing you some tractography so we can have even a better image of what we're looking at. So I'll start with axial as always, and as we said, first of all, please just appreciate how different the image looks. This is T2, 7 Tesla, and this is T2. I think this is 2 or 3 Tesla, or maybe this is 2 Tesla, I'm not sure. But there's a huge difference between the two. And here you can see the central sulcus. Again, it usually has the omega shape, but it doesn't have to be a perfect omega shape. So this is the central sulcus here with the pre-central gyrus and the anterior to it, and the post-central gyrus posterior to it. We have here and here the superior frontal gyri, here and here the middle frontal gyri. And I wanted to also show you, yes, I think this is it from this cut. This is way down, but I told you, I just wanted to show you very important images that I think will make things easier for you guys. So if you can see these transverse lines here, these are the white matter of the corona radiata. Okay, this is how it looks like on a very cool image on a T7, on a 7 Tesla MRI machine. So this is the fibers of the corona radiata here and here. And here you can see the tracts. So this is the cingulum, the tracts of the cingulum. These are the tracts of the corpus callosum, and these are the tracts of the corona radiata. Again, this is the cut where at the level of the lateral ventricles, we can see the anterior horn here and the occipital horn here. The head of caudate, as we said, the head of caudate, this tiny vessel is the anterior caudate vein. It drains the caudate and joins the thalamostriate vein with the anterior septal vein to form the 2 internal cerebral veins, as we said, going backwards. So if you can see, this image is very nice. This is a very, very nice image. So head of caudate, and here we have the thalamus, and we have the putamen. Here we have the genu of the corpus callosum. Here we have the splenium. We can also call this forceps minor and forceps major of the corpus callosum. And if you remember in one of the images, I told you this very thin gray line that is the optic tract. Here it is. It's showing beautifully here. So this is the optic tract going to the occipital lobe. And here you can see it, forceps minor, forceps major, and parts of the optic tract here and here. And yeah, this is more down. And here we can see the superior frontal gyrus, or what they call the medial orbital gyrus here, and the gyrus rectus, the start of the gyrus rectus, we can see it here. Here you can see the anterior commissure here, and the third ventricle here. Again, this is the collateral sulcus. I'm not sure if there's more senior doctors among us. This is the collateral sulcus, and here we have the medial posterior choroidal artery going into it to go into the temporal horn of the lateral ventricle. And at this cut, because we have here the Sylvian fissure here and here, we can start seeing the temporal gyri. So here we have the superior temporal gyrus. Here we have the middle temporal gyrus. And here we can see the start of the culmen, the part of the anterior lobe of the cerebellum. This is a more zoomed in image. I'll skip it. Again, gyrus rectus here, gyrus rectus here. And we have the crus cerebri here, and here we have these the substantia nigra. Here it's showing more nicely than the previous images. We have the red nucleus here and here. What else I wanted to show you in these images? And these are the tracts. I mean, it's complicated, and I think we can do a lecture about the tracts alone, because I think they need a lecture on their own. But I mean, just appreciate how nice the image is and how complicated our brain is. It's amazing. Again, we can see here the crus cerebri, the substantia nigra here. We can see the optic chiasm here, and we can see the internal carotid giving the middle cerebral here and here. And the start of the fourth ventricle, these are the temporal pole here and here. This is a more zoomed in image. So internal carotid giving the middle cerebral, and we should be able to see the PCOM, and here is part of the posterior cerebral arising from the basilar and making its way around the midbrain. Again, this is the pons. If you remember, we said this is how the pons look like. And this is part of the fourth, the very start of the fourth. About the sagittal cuts, as we said in the other images, this is the pars triangularis here and here, and this is the here, and this is the opercularis. And here we can see the central sulcus. It's basically the one that's going, the only one going to the midline, all the way to the midline. And it's the one almost touching the sylvian fissure. So this is the central sulcus. So above, anterior to it is the precentral gyrus, and posterior to it is the postcentral gyrus. And with the sylvian fissure, we go up, and we have the supramarginal gyrus, and we have the angular gyrus in the next. So sylvian fissure, supramarginal here, angular here. Again, central sulcus going down, precentral, postcentral, pars triangularis, pars opercularis. This is the superior temporal gyrus, the middle temporal gyrus, and part of the inferior temporal gyrus, because it goes down. It curves under on the undersurface of the temporal lobe. Triangularis, opercularis, superior temporal gyrus, middle and inferior here. We're going more to the midline. You can check this to be more oriented. So we're going, this is the midline, we're going more towards the midline. And this is the globus pallidus here. This is the pulvinar. This is the crus of the cerebrum. This is the middle cerebellar peduncle going down into the pons. This is the dentate going into the cerebellum. I'm sorry. This is the dentate nucleus with a more detailed image of the cerebellum here. This is parts of the internal capsule, the posterior limb of the internal capsule here. This is more towards the midline, so we can appreciate the corpus callosum more, and the cingulum more, the cingulate gyrus more. And we have here the red nucleus with the substantia nigra underneath, pons, dentate. I mean, these are the structures that just stare right back at you. And this is the parieto-occipital sulcus starting to show here. So this is the cuneus, this is the precuneus. And this is how the tracts look with the corpus callosum, with the cingulate, and with the corona radiata and the internal capsule going down to continue their path. This is more towards the midline, or this is exactly midline. So again, corpus callosum with all of its parts, internal cerebral veins going to the vein of Galen and going to the straight sinus. Here we have the mammillary body, here we have the optic chiasm, and anterior and posterior commissures here and here. Again, for the functional people, they're super important. And I'll finish with these cuts from the coronal. Again, just to be oriented how the gyri are arranged. So this is the superior frontal gyrus, the middle frontal gyrus, and underneath we have the orbital gyri with the medial and lateral and anterior and posterior parts. And we'll go more back. I went way back because I can't, again, I can't show you all of the images. This is the body of the corpus callosum. It looks very nice here. It looks very prominent. The septum lucidum with the columns of the fornix. We have the head of the caudate. We have the putamen and the globus pallidus. They're showing here. Again, just to see how the tracts look like, how they go. They collect the information from up and then they go down, and they pass between the caudate and the putamen. So this is how it goes, the pathway for it. Red nucleus, substantia nigra. I think now we can imagine exactly how the red nucleus and the substantia nigra look like. Lateral ventricles, columns of the fornix, septum lucidum, internal cerebral veins in the roof of the third ventricle. Here, when it comes to the temporal parts, here we have, I'm not sure if it's showing here, maybe, yes, here. Here we have the inferior temporal gyrus, here we have the fusiform gyrus here and here. Here we have the middle temporal and the superior temporal gyri here. So again, the superior and middle can be appreciated from the sagittal view, but the inferior ones, I think, because they're again at the basal surface of the temporal lobe. We're going way back. You can see, check this. So dentate, because these look odd, so we should know what this is. This is the calcarine sulcus here, and I was asked this question a few weeks ago, and I didn't know how to imagine where the calcarine sulcus is on a coronal section. So the idea of this lecture is just to point out to you what you know, what you don't know yet, and to urge you to go and search and look for yourself what these structures are. Okay, so this is the precuneus here, this is the cuneus here, according to the calcarine sulcus. This is the cerebellum, this is the tonsil, this is the optic radiation going to the occipital lobe, and this is the last image of the coronal section. I hope I didn't take so long. I hope I pointed out some of the things that you didn't know, that I'm urging you to go and look for yourself. In conclusion, we should know our anatomy. Our eyes will not be able to pick up the pathology if we don't know normal anatomy. So keep looking at images, keep practicing. As I said, make up your own routine of looking at the image so you can always see everything and not miss out on anything. No one can teach you all of the brain anatomy in one session, so please go ahead and do your homework. It's a daily exercise. Don't skip. This is how I was taught. This is how I'm still practicing in my clinic in the ER. I always look at the image and I ask myself, what is this? What is this? If I don't know anything, I'm not shy. I will not shy away from asking someone, what is this? And at the end, I want to take a minute to just remember the over 110,000 Palestinians killed or injured during the war in Gaza for the past 5 months. More than 14,000 of which are children, more than 8,000 of which are women, more than 700 of them are healthcare professionals who were killed or injured. Almost all hospitals are bombed. Almost all of places of worship are bombed. And I want to urge everyone and ask everyone to pray for the peace and dignity of the Palestinian people. Thank you.
Thank you, Dr. Asil, for this fantastic and extraordinary lecture. By the way, me as a Yemeni nation, I would like to sympathize with our sisters and brothers in Palestine and Gaza exactly. Um, for this tough situation, and I hope everything is gonna be good, and I hope, this genocide will be ended as soon as possible. Thank you, dear. John, are you over there? Hi, John, can you hear me?
Yes, any questions from the panelists? Ahmad, any questions from the panelists?
Let them raise their hands if they want.
Yeah, that would be another option. I guess not. Okay, very good, Ahmad. Thank you very much. And Dr. Dr. Sabea, are you there, Dr. Sabea, right?
Yes, I'm here. Yes.
Yes, this is the end of the didactic portion. But what we're trying to do, Dr. Sabea, is to include the medical device makers and pharma into the presentation so they can support us financially.
Sure.
We all know there's a lot of societies in the world that just can't afford to do webcasts, and we've been doing them for free for our med for 5 or 6 years. However, we'd like to bring medical device companies into the webcast, and I'll show you how we're going to do this. I'd like to introduce Ram Kumar. He has a company, Sanmar, in India, and we're gonna give kind of a presentation of his product. Okay, Ram, it's all yours.
Yeah, thank you.
You
So
want
I'm
to?
just sharing my presentation screen. Just allow me a few seconds.
Okay. And this is interactive. If you want to ask anything, just ask. Okay. Go ahead, Sam. Go ahead, Ram.
Yeah, thank you, Dr. John, and thank you all the participants and attendees. So I'm Ram Kumar from Sanma Mediners, Chennai, India. So what we make is we make surgical operating microscopes, 3D exoscopes, and robotic assisted endoscope pump. So this product, this last robotic endoscopes, still under evaluation, clinical evaluation. So apart from that, we have a surgical optic microscope and 3D exoscope for neuron spine applications. So we are the first Asian company and third brand to make microscopes for all microsurgical procedures. And we are the fourth global brand making microscopes for neuron spine plastic and reconstructives. So next to Zeiss, Leica, and Metaka, we are the fourth brand making all adaptable features for the neurospine applications. So these are the advantages and top-notch features of our optics, ergonomics, and other top features of the product called, and the brand name called Ocula, the model. And the main advantage is that with the upper chromatic optics and the BBR coated optics of the microscopes, which gives the best 3D stereoscopic microscope visuals. So this is the optics of our product with the 0 to 210 degree tiltable. So with the options of 10x or 12.5x eyepiece. And so we have a 1:6 ratio with a continuous zoom controlled with both hand grip control as foot switch control as an optionals. And we have a working distance, continuous working distance of 200 to 500 variable. And the illumination system, we have a LED light source with the standby source with a daylight lux of 2.4 lux. And optional, we give us a xenon light source. And this is contains with of a 6-axis electromagnetic brake system and a joystick powered head movement for swivel and axial position for fine movements. So this helps without accessing excess 6-axis brakes. You can just move the optical head part as per their position. And we have the multifunctional hand grip controls for focus, zoom, illumination with XY movements. So this is that hand grip controls and foot assist controls for all these features. So optionals we give for as joystick controls, focus, and for the electromagnetic controls, and as well as zoom. And these are the 30-degree inclined eyepiece extender, angulated extender that ensures the position of the neurosurgeon where he can just stand upright and he can continue his long procedures where it can be in the next chain, you can just free. So that is the main advantage of this model, Oculus. And we offer with two optional assistant scopes like the side co-observative and face-to-face for lateral view with the optical bridge of face-to-face with the tiltable binos. And our optional filters, we provide yellow 560 and our IR 800. And for the imaging documentation system, we offer full HD or 4K with live recording and still image storage of capacity with internal memory 1 TB or 4 TB. Monitor we offer as an optional, like based on a 24-inch or 27-inch or 32-inch, based on the availability or the need. These are the package of this imaging system along with the microscope. So thank you for the opportunity. Thank you all the panelists and attendees. Thank you, Dr. John.
Okay.
So I request if there is any queries, please ask me.
Yeah, any questions or comments, Dr. Sabea? You don't have to comment. Okay, that's fine. Okay, Ahmed, any comments or questions?
Well, if you permit me, I would like just to share my screen for, okay, screen just.
Yeah, I'm just getting this off here. Okay.
Okay, just a second. Okay, this. Yeah, I would like just to, if you permit me, of course, I would like just to advertise for this lecture 2 weeks from now with Prof. Gal from Mayo Clinic and also Abita Shah from India. That will be taking place in the 1st of April, I mean 2 weeks from now. Thank you.
Okay, very good. Let's continue with Ram. Does anybody have any questions or comments for the the microscope that he showed? No one? Okay. That's okay. That's okay,
I think
Ram.
someone is asking how much is the price of the exoscope.
Yeah.
Yeah.
Go ahead. Go ahead, Ram.
The exoscope starts with just just a sec.
Yeah, sure.
Okay, is there anyone to talk?
No, hold on.
Just a second. So I'm just converting into the dollars.
Yeah, I should have explained this to you, Ahmed. I'm sorry.
It comes approximately $180,000.
Okay. Okay, we got that. Okay, very good. We won't keep everyone.
Can I ask also?
Yeah,
Can I ask something?
Of course.
Yes.
Of course.
Where is your major market? Where do you usually? What's your major market?
Our major market is in India, and now we are exploring in Middle East and European countries.
Any country or anyone in the Gulf area, in the Gulf region has
Yeah,
purchased?
we have installed in Oman and Dubai, and the
Okay.
CIS countries in Uzbekistan, Kazakhstan.
Okay, great,
Yeah.
great.
And in
Very
Asia
good.
Pacific, we have installed in Malaysia, Philippines, and Indonesia.
Great.
Okay, Dr. Sabay, I'm trying to convince vendors to advertise this way.
Yeah.
Thank you.
Well, then we come,
Thank you.
then
Thank you,
when,
Dr. Spay.
then we approach the neurosurgeons and we say, the conference is paid for. Now you just find a seat.
That's true.
That would be great. Anyways, thanks, Ram, and thanks, Dr. Sabay, for taking the time.
Thank you. Thank you,
Very
Dr.
busy
Spay,
day.
Dr. John.
Okay, thank you, everyone, for
You're
coming.
Thank you.
Okay, good
Thank
day,
you.
everyone. Thanks,
Good day.
Good day.
Ahmed.
Day.